We will now begin with the afternoon portion of our conference. So I would like to invite our first speaker. That's Dr. Lorenzo Ferry. Now, he has a very impressive bio that you can read in the program brochure. But just to give him a little bit of an introduction, so he is a surgical oncologist, director of the gastrointestinal cancer program at McGill University. He has a special interest in translating research, and as we mentioned before, he's the lead researcher in Storming Cancer, which is a project that looks at the role of inflammation on cancer that my gut feeling is actually very much involved in. So I would like to introduce Dr. Lorenzo Ferry, please.
Well, thank you so much, Kat. It's been an absolute pleasure to be here, and to thank you for inviting me on such an important day. I'm going to talk a little bit about my research. I'm going to talk about how the innovations in gastric cancer research and the implications that this may have for therapy now and potentially in the future as well. There's one caveat that I should say that a lot of the work I do is both stomach and esophagus cancer, and outside of many places in North America, in Europe, and in Asia, these two diseases are sort of lumped together and treated similarly and studied similarly. So I will intermittently talk about stomach and esophageal adenocarcinoma, and there's a reason for that is because a lot of the same molecular drivers are similar for both those diseases. So when I was asked to give this talk, I asked Teresa if she wanted me to talk on one aspect or the other aspect. She said yes. And so I'm going to talk about both aspects of translation research that we do here at McGill University in Montreal. I'm going to try to be a general theme for both of these sub-talks is how endoscopic-based therapeutics can really drive change in how we treat stomach cancer, both for early disease on your left, as well as more advanced disease on the right. These are pictures of two different cancers and how the gastroscope itself can help drive therapies and drive innovations. We'll start off with the early disease. We know that surgery, this is an operation that I did maybe 15 years ago. Surgery for stomach cancer is very effective. It gives you, in combination with other therapies such as chemotherapy or radiation therapy, does give you the best chance of cure for this cancer. And it's very effective in obtaining the goals that us oncologists like to look at, the number of lymph nodes removed, if the margins are all negative. It's very effective for that. However, it's really important that we consider the outcomes that are important to patients. What is the quality of life whatever treatment that we're doing on people? How does it impact their day-to-day living? What's the recovery and the return to normal activities after an operation such as this? And we, as you will hear later on, how important it is and how much it impacts our eating, our ability to eat, and all the side effects that encompass it. So I want to talk about a few research innovations that we've done in order to help improve the recovery after surgery. I've been really fortunate to work with one of my colleagues at McGill, Leanne Feldman, who's really the world pioneer in enhanced recovery after surgery. It's a concept where we try to really improve the outcomes that matter most to patients, which is improved recovery, improved quality of life. And this is sort of a multimodal, multidisciplinary approach that really tackles not the operation specifically, but everything around the operation, how it encompasses all the aspects that accompany a procedure where we're trying to remove a stomach cancer. If we look, this is a sort of a schematic diagram for enhanced recovery in general. We have on the x-axis a level of functioning, and on the y-axis the patient trajectory through the perioperative period. And what we're trying to do is really limit the amount of time that a patient spends below this acceptable level of functioning. So after an operation, there's an expected reduction in the level of functioning because of the stress of the operation and so forth. Then after, there's a slow recovery, and hopefully they recover back to normal. That's a general trajectory. What we need to do is try to find some ways to limit the time the patient spends below this area through what's called an enhanced recovery program. So we're one of the first program centers in North America to really look at this both for esophagus and stomach cancer. We've been doing this for roughly 12, 15 years. So one way to do it is to quicken the recovery. So we actually reduce the amount of time let's go back to this. reduce the amount of time that it takes to recover from this operation. That's termed rehabilitation. Another way is to decrease the deterioration by reducing this complications, diminish the surgical stress. So again, the people spend a lot less time below this. And finally, the next way is really to look at how we can increase the basal level. How can we increase this level here so patients spend less time because they're already much stronger to start to undergo an operation? All these concepts really encompass the components of enhanced recovery after surgery. This was first pioneered by Heiner Kellett in Denmark. We're probably one of the first ones in North America to really adopt this. I remember as a resident in the mid-90s seeing Heiner Kellett speak at McGill. And we really were an early adopters of this concept, which is really remarkable. It really has changed the way we treat patients in the perioperative period. As I said, it's a standardized, integrated, multimodal, evidence-based approach to all aspects of perioperative care. So what we're trying to do is increase the things that accelerate recovery, decrease the things that delay recovery. Very mindful sets. And previously, you may have noticed, we really changed the way we look at an operation by getting input from many people, not just surgeons. We get the input from the patients, what is important in their quality of life. We get input from the nurses, physiotherapists, nutritionists, anesthesiologists. Everyone comes together. We try to find how can we improve the patient experience through the perioperative care. A lot of it has to do with education. I'll show you some education websites that we've developed over the past 15 years. Standardized orders. Everyone has to be on the same page. The nurse, the patient, the physician, everyone who sees someone who's undergone a gastrectomy, they all have to be on the exact same page. So we have to know there has to be daily care maps. What's going to happen on day 1, day 2, day 3. The general concept is early mobilization. Get up out of bed straight away and really remove drains. When I was training, we used to have a tube in the nose after gastrectomy, a feeding tube, a tube draining fluid around there, an epidural, a catheter in the bladder. People had more tubes than they had holes. So we really moved away from that completely. We started feeding people immediately. Again, when I first trained, people were kept fasting for over a week after the operation. That has changed completely. We try to stay away from opioids, like morphine-based medications. They have a lot of side effects and obviously a lot of problems with long-term effects that we'd like to avoid. And we also want a well-defined discharge criteria. So all these aspects go into an enhanced recovery pathway. So if surgeon A is operating on the patient versus surgeon Z, it's the exact same approach. Everyone knows exactly what's happening and improves outcomes. And we've shown that in multiple disease sites, particularly in gastric cancer. This is the McGill Enhanced Recovery Program from gastric cancer surgery. We're undergoing a trial right now, which will have that published relatively soon. But this is basically it. It's a lot of patient education materials. They're all available both in paper format and a booklet, as well as on our website. It explains what the operation is, whether or not it's a subtotal gastrectomy or a total gastrectomy, removing half the stomach or all the stomach. And irrespective, the patient gets treated exactly the same way. So we have a 4-day planned admission. There's absolutely no drains. The patient has no drains whatsoever, no epidural, no catheter in the bladder, no tube in the nose. Patients are up walking the evening of the operation. They start drinking immediately after the operation. And they put on a regular diet, a regular post-gastrectomy diet. And I guess you'll hear a little bit more about that later on by one of our speakers, about the importance of nutrition in this area. But on post-op day 1, and we really avoid all morphine-based medications. So people are on anti-inflammatories and so forth. So with this approach, we've been able to reduce our length of stay from used to be 7 days down to around 4.5 days on average. So really, it's a concept of sort of global looking at how we manage patients, try to break down some of that surgical mythology that has existed. And things that we used to do just because we're taught to do them. We basically studied every aspect of an operation, broke it down, studied every one of them, and determined whether or not we actually had to leave a drain in. Do we have to put a Foley catheter? Do we have to put a nasogastric tube? We removed all those aspects, and really we try to streamline the patient care. So it really improves the patient's recovery after this operation. Another concept we looked at is the concept of exercise and nutrition pre-habilitation prior to an operation. You're really trying to bolster up someone. So it's better to wait. Everyone wants to have an operation the next day. Sometimes it's not the right thing to do. We usually try to wait 4 to 6 weeks from the time we decide to do an operation prior to booking that operation, because we really want to give 4 to 6 weeks for somebody to get stronger prior to doing that. Again, we have a very dedicated pre-habilitation team with physiotherapists, kinesiologists, nutritionists, and psychologists in order to improve exercise, nutrition, as well as anxiety coping prior to an operation. We've shown both in stomach and esophageal cancer patients, this is a randomized trial we did published last year, or 2 years ago, showed that with patients who undergo this pre-habilitation program, where we get exercise at home for 4 to 6 weeks, we can actually improve their strength prior to an operation, reduce their complications, and even after the operation, you see they're actually higher than they were prior to the exercise. So this is a concept that we've really taken to heart, and we've actually started to do it from the time of diagnosis. As you know, many people may have treatment before an operation, and we've actually moved this. We're underdoing a trial right now where we're looking at using pre-habilitation during the entire 2 to 3 months of treatment prior to an operation to really strengthen someone to make sure that they're ready for an operation and improve their outcomes. This is an area that we've invested a lot of energy and effort into this, and I think it really has legs and something that I'm very supportive of our group. And I've really been, a lot of this has been driven by this one anesthesiologist, Dr. Franco Carli. He really is a world leader in the area of pre-habilitation. So part of enhanced recovery programs is really trying to reduce the stress of the operation. And there's been a general move in all cancer surgeries, moving away from the traditional open operation to that of a laparoscopic procedure. Here I am with one of my fellows and another one of my residents doing a laparoscopic gastrectomy. We've gone from a large open incision to very small incisions. We started doing this around 15 years ago and transitioned gradually into laparoscopic surgery. And we've shown that even if we compare the laparoscopic surgery versus the open operation, we're still able to take out a large tumor, the whole stomach, in fact, if you will, even through a small incision like this after you've done all laparoscopic approach. And we're able to do around 75% of all gastric cancer surgery is now performed laparoscopically, at least in our center and many centers across North America and the world. We've shown that there's an equivalent lymph node yield, and that means we do a good cancer operation, and the patients go home shorter. There's a much shorter length of stay, and there's less pain with increased recovery. So that's really now become a mainstay in the management of locally advanced gastric cancer. So we've gone from big open incisions to small incisions, but still the same operation on the inside. What about no surgery whatsoever? And that's really a new area that we've looked at maybe 12, 13 years ago. This really started to take off in Japan and Korea, where we're trying to avoid taking out the organ, the stomach, at all for a subset of patients with early cancers. We can take out a cancer like this entirely endoscopically, like using the gastroscope. So the patient undergoes a gastroscopy, it's a bit longer than the usual one, but we're able to scrape off the superficial lining of the stomach in order to spare the rest of the organ. So there's none of those side effects such as difficulty eating or bleeding, complications, or recovery, but we're able to take out this tumor effectively. It has to be certain criteria that the cancer has to fulfill. That means there has to be a very extremely low risk of having spread to the lymph nodes outside of the stomach. So it has to be really limited to the stomach. And so that means that there usually tend to be superficial tumors. There has to be well differentiated, and they have to have something called no lymphovascular invasion. We'll talk about that in a bit. And it has to be amenable to be able to take out the whole thing at one spot. Now, this is something I learned. I went to Japan in probably 2008 to learn this technique. We started doing it in North America. I had to go in order to get more experience. There's one gentleman doing it in the Americas routinely down in Colombia. So I went down to Bogota for another few weeks to learn the technique a little bit further down there. And we started doing this routinely around in 2009 in Montreal. Since then, we've done around 150 of these type of operations. I'll show you what it looks like. So this is the standard endoscopic resection of early gastric cancer is something called EMR. That's pretty routine. That's done in many centers throughout the world. So it's very good for small tumors, less than a centimeter. You basically suction it entirely up in here, and then through a gastroscope, and you sort of you take it out, and you're able to get a decent margin. It's really good for tiny cancers. But what happens if you have a larger stomach cancer like this one, which is around 2 or 3 centimeters? You end up having to cut it out multiple bits and pieces, and it's really hard for the pathologist to know if you have the whole tumor out. So what we learned in Japan, and what they've done in Japan, is something called endoscopic submucosa dissection, which is using a regular gastroscope. You use specialized instruments, and for large lesions like the 3 centimeter, you basically dissect it off of the stomach and leave the stomach intact. This is what's really made a difference, because it's really hard to find. It's hard to find the very small cancers. Those are extremely rare. This is what we see more often: is these larger, more diffuse tumors in North America. So what does it look like? This is a patient did an endoscopic submucosal dissection around a year ago. It's done in the regular gastroscopy suite. There's no general anesthesia. It's as if you're coming in for a regular gastroscope. Just takes a little bit longer. It takes between 45 minutes and an hour to do this procedure. So here we can see the tumors right here along the what's called the incisura, the lesser curvature of the stomach. I mark it out with little electric cautery margins. Then I inject this lesion off of the muscle so I can safely dissect off of it with a solution. And then I start cutting the whole tumor out with a specialized equipment, as you can see here. Eventually, I cut the lining of the stomach, and you can see the tumor is right here, and this is the margin here. And we're able to remove this entire thing off the muscle. This is the tumor here. This is the muscle of the stomach. And at the end, you end up with a very large ulcer that heals in around 6 to 8 weeks. And this is the lesion right here, and you can see right now we have the entire lesion. It really has to be superficial. It can't be go into the muscle. And after it's taken out, we have a look at it under the microscope. The pathologist looks at it, looks at what the tumor looks like, and looks at to make sure there's no tumor at the margins, where the deep margins or the circumferential margins, and looks at things we talked about that may that may increase the risk of having little microscopic cancer cells in the lymph nodes. So if all these are the criteria are met, if it's it doesn't go too deep it goes the maximum 0.2 millimeters into the submucosa. It's well differentiated. Does not have lymphatic invasion. This is all you need. You can take take this out, and you can leave the rest of the stomach. So we've done, this is a study where we compared it to patients undergoing a laparoscopic gastrectomy, and actually we take out half the stomach versus doing this endoscopic removal. We found that there was an early discharge home. Most patients go home on the same day of the procedure. There are fewer complications, very rapid recovery. It's as if you've just had a regular gastroscopy, not a major surgery, and the survival is not impacted. Again, this is for early tumors. So what we try to do for tumors that are a little bit more advanced is combine that endoscopic resection with a new concept called sentinel lymph node mapping. Is patients who have some of the features that are slightly higher risk for spreading to the lymph nodes, we can actually biopsy those lymph nodes. And if they're normal, leave the stomach. That's the concept that we're moving towards. We're still studying it right now to see whether or not it's feasible to do that. But you can see we can inject a certain dye right next to the stomach, and this follows the lymphatic vessels and it goes to the lymph node. So I know exactly which one should have the tumor if it's going to have a tumor. I take out that lymph node. If the lymph node has no cancer, even though there may be a tumor that's a bit deeper than we would like, then we can leave that stomach. That's the concept we're trying to move towards in order to save people's stomachs, remove the cancer, but save the stomachs. You don't get any of the side effects. So unfortunately, although that works for people with early cancer, most of the people we see in North America have more advanced disease, more aggressive cancers, which are not amenable to taking out the tumor. And for these patients, we know that the standard of care is to give chemotherapy both before and after a surgery for those who are localized to the stomach or the lymph nodes. There's a study that we did way back. This is when I first started on staff in 2005. I started this trial looking at something called docetaxel, showing that if you give this chemotherapy before and afterwards, you can really improve outcomes for these aggressive cancers. So that has been followed by another study, a more recent one. This is now which is the standard of care by Al Batran, also out of Germany, which showed that what the standard chemotherapy right now really is docetaxel or FLOT-based chemotherapy, both before and after surgery. It is effective. It works in over half the people who start the treatment, but still, around half the people, it doesn't work. And there's a high rate of recurrence. We also looked at other biologics, such as immunotherapy and special antibodies, and they tend to be very limited improvement. There are some people who have Herceptin-based antibodies that can work, but overall, biologics have not succeeded very much in this disease as compared to colon or lung cancer. And part of that's because you don't really have very good biomarkers. So we're still stuck in that era, that a 50-year-old oncology chemotherapy-based treatment paradigm, where it's a trial and error method or approach for systemic control. And it really has not changed very much in the 1960s. So there's a good chance that even if we give chemotherapy to someone, there's around half the patients they may not benefit people. So it's just trying out and see if it works. That's not really reassuring for our patients. It's not reassuring for us either. So can we be smarter about the way we give neoadjuvant therapy for gastric cancer? This is a concept we started doing. It sort of morphed out of the Storming Cancer project that we are working with another 8 other PIs around the world. And it's really, we're trying to look and see if we can find out the way we can predict how someone's going to respond to chemotherapy based on endoscopic biopsies and looking at those endoscopic biopsies effectively. So at current status, what we're doing right now, this is standard of care, is someone that gets diagnosed with a locally advanced or a gastric cancer, that's quite a big cancer in the stomach that has lymph nodes. They get 4 cycles of what's called a docetaxel-based chemotherapy or FLOT before surgery. They undergo surgery, but what happens in more than half the patients is that this person had no response to that chemotherapy. Although half people do respond, half of them don't respond. Then what ends up happening? The standard of care, even though this gentleman did not respond to his treatment, we give 4 more cycles of chemotherapy. It doesn't make much sense, but that is how we think about oncology currently. And it may or may not work for this gentleman. Maybe it might prevent the cancer coming back, or it might not. So can we be smarter about this? Well, one way is one way that we wanted to answer the question. This is a group we started maybe when I first started on practice in 2005. We started looking at our biobank, looked at the tissues that we removed from people who had undergone chemotherapy or undergone surgery or prior to chemotherapy, and we tried to look at the tissue that we had available. We had over 1,000 patients with esophageal and gastric adenocarcinoma. And more recently, we started to biopsy and control over the past 7 years. We really looked at taking live cells so we can actually study them and how they act outside the body. Maybe that can give us an understanding of how people are going to respond inside the body. So this is a concept using organoids and patient-derived xenografts. And so we have around 100 and 150 of these living cells that are from people who have stomach and esophageal cancer and carcinoma. And we can study how those work outside, how they respond to treatment outside the body. So what are organoids or patient-derived organoids? They're sort of 3D cell cultures that maintains all the different cell types of a tumor. And we're using them as patient avatars for pre-clinical drug testing. So if a drug works on these organoids, we think it may work on the person. But we have to find a way to translate that and move that into the clinic so patients can actually benefit from this. So this is an example of someone's organoids, where we can see beforehand we give them the same drug that we would give them in the body. You can see these things start shrinking. See if I can get that going again. I don't see I can get this going again. But as you can see, after you give these drugs, well, that's not working at all. After we give drugs to these patients, you can see they start shrinking. Means that they're dying from the chemotherapy. So that allows us to study the drug outside the body to make sure that it actually works before we give it to someone. This is an example of someone who responded extremely well versus someone who did not respond very well. And you can see this one just shrivels up to nothing, whereas this one starts to contract a little bit, but likely has some resistant tumors that will restart regrowing. And we know that we've also shown that the way these organoids respond in the petri dish is pretty much similar to how they respond outside in someone in the actual patient. So this is how it is in the petri dish. This is how it is in the patient. Someone who responded really well, you can see wherever as this curve moves to the left, that means that their body respond extremely well as well. So we can show that you can use these organoids outside the body to see how the drug is going to work inside the body. This is an example of how we can use this clinically. This is a gentleman who had a esophageal adenocarcinoma, and we tested the drug the patient got. We did the biopsies before with an endoscope before they got drugged. We tested the organoids, the drugs in the organoids inside in ex vivo outside in the petri dish. The patient got those 4 cycles. We tested again, and it's still responsive. So this curve means that it's responding to the chemotherapy. So at diagnosis, it responds. after surgery, whatever tumor was left over still responds to the chemotherapy. That means it makes sense to continue giving chemotherapy to this patient. So this patient went on to get 4 more cycles of chemotherapy. However, in this gentleman, in this woman, you can see when at the diagnosis, it responded to the drug. However, after we took out whatever was left over when we did the operation, there's still some tumor left over and it become resistant. So it makes no sense to continue giving the exact same chemotherapy to this patient. So this is someone that we should alter systemic therapy. But what chemotherapy should we give this person if they have resistant tumor that's not responding? So one way to look at, we do a lot of sequencing of all our patients. We do whole exome sequencing, and many of you may have heard of sort of like a 23andMe type approaches, the Foundation medicine, where they just sequence a small number of maybe 200 to 300 number of genes. This whole exome sequences all genes in the body, and you can see if we look at this fish plot, these are the different clones and mutations at the diagnosis. After the 4 cycles of chemotherapy, these get killed off completely. However, these clones are still responding. So it's important to tackle these clones now, or a new clone that arose. So this gives us an idea of what chemotherapy to use in people who still have tumor at the end of treatment. What we can do what's called a high throughput drug screen that's based on the information that we get from sequencing. These are all organoids that had this mutation, and you can see some of these antibodies may actually work. There's an antibody against the MEK inhibitor. It may work against these specific tumors. So our goal is to try to identify mutations in the tumor, in resistant tumors, test them outside the body on these organoids, and see what we can give to someone. For example, this is a patient who had a metastatic gastroesophageal junction adenocarcinoma, and he has a amplification in the EGFR gene. We know that he's no longer responded to oxaliplatin, but he's responded to this EGFR inhibitor, gefitinib. So those are concepts we want to be able to give this patient, is to target the treatment. So ultimately, can we be smart about neoadjuvant chemotherapy or therapy at all for patients with gastric cancer? I think we can. I think we know that this does work. The FLOT or Taxotere-based chemotherapy works in a large number of patients, but in around half of patients, it doesn't. So in these patients, this is where we want to use live testing. So we take the organoids, test those drugs outside the body, sequence them, find out, do it through a drug screen based on the sequencing targets, identify which ones will work, which ones that we can use in a targeted manner. So not only identifying the mutations, but also testing those mutations outside the body. So whatever patients get, they don't have this trial and error method. We know it's going to work. So the important thing to do on this, what we're really trying to do is work on a pipeline that works, that is in the same timeline that's important to patients. It doesn't help us if it takes us 6 months to do this. So if we have to be able to do it in 3 to 4 weeks, because that's the amount of time that we need to before we start treatment. So what we've really worked on is a pipeline where we take the biopsies, we organize, we make those organoids, we sequence the tumors in the first 2 weeks after the biopsy. This is biopsy when they were first diagnosed. Then we analyze them, identify which drugs to use on a drug screen, do the drug screens on the organoids, and after 3 to 4 weeks, we hope to have a completed drug screen in someone's individual tumors, so we know which drug to give to that person. So that's not now, but I hope to be able to have that relatively soon. So we are working on this pipeline. This whole concept is established in the lab, and we are really moving towards a really personalized approach that's not based just on the mutation analysis, but confirming that by targeting certain mutations in that cancer, we can treat it. Well, I think I'm over my time. I'd like to thank the organizing committee for inviting me to talk a little bit about something I'm so passionate about and some of the research that I'm doing.
Thank you so much, Dr. Ferry. Speaking as a patient who was treated about 9 years ago, I can't believe how far things have come in the past 9 years. Wow, there was such an incredible amount of information there, and hopefully we can have your presentation up on our site. Again, thank you so much. I know how busy a schedule you've had this past week, so we really do thank you for all the information that you've just given us. I know that there's a number of questions, so if you hopefully stay on and be part of our panel discussion, there's a lot of questions that have already come through.